Hi everyone, this is your PowerPoint voiceover on integumentary or skin disorders. We're going to cover different clinical manifestations, mode of transmission, treatment for bacterial, viral, fungal, and parasitic skin infections, discuss the pathoclinical manifestations, and nursing care for inflammatory skin conditions like your different types of dermatitis and psoriasis. And we're also going to talk briefly about skin cancer. And now for this voiceover, I'm really only going to focus on some of the key disorders you might see in the clinical setting. First up is cellulitis. It is usually caused by staph or strep, so it's usually caused by bacteria. And the bacteria that cause cellulitis can spread really rapidly, entering your lymph nodes and your bloodstream. So it's really important to notify your doctor or healthcare provider if you notice the signs and symptoms as soon as possible. Recurrent episodes of cellulitis may damage the lymphatic drainage system and cause chronic swelling of the affected limb. It does involve the deeper connective tissue, and that localized areas of inflammation can enlarge rapidly with redness, warmth, edema, tenderness, pain, often accompanied by fever and lymphadenopathy. And it can occur as a result of a secondary bacterial infection of an open wound or skin trauma. And some of the most common areas are the lower legs and areas of persistent lymphedema and areas of skin trauma, like leg ulcers or puncture wounds. And common treatments for antibiotics may include your penicillins and cephalosporins, and you might require systemic antibiotics depending on the progression. And we want to make sure we treat it by washing with soap and water, applying antibiotic ointments, and covering the wound, making sure it's nice and clean and dry. MRSA, I'm sure you've dealt with that at some point in the clinical setting. Need to be on contact isolation for this methicillin-resistant Staph aureus that are resistant to certain antimicrobial soaps and most types of antibiotic therapies. Some people are colonized with MRSA. That means you can carry it in your nose or your skin, but you're not necessarily quote-unquote sick with the MRSA infection. If you do have the signs and symptoms, such as it looks like a boil with abscess, pain, and swelling, you are much more likely to spread MRSA because the infected area contains a lot of the germs that cause MRSA. We can prevent it by making sure that we assess risk factors for being in certain communal environments. And you can use Bactroban inside each nostril twice a day for about 5 days. That is used to decolonize MRSA in the community. We can do chlorhexidine showers, hibiclin baths pre-op. And we treat it with either IV Vanco or flagyls. So typically in clinicals, you'll see that if you get a new admission from someone that lives in a communal environment like a nursing home, they will typically do a MRSA nasal swab to screen for the presence of MRSA. And just general treatment and education points for bacterial infections. Hand washing is key. Not sharing personal items. And we do recommend daily bathing with an antibacterial soap. You can use warm compresses for comfort, for the pain. We do want to make sure the skin is nice and dry when we do clean it, and avoiding clothing that rubs those lesions. Initially, you might use topical antibiotics like bacitracin, neomycin, neosporin, Bactroban for mild infection, but people that get systemic signs and symptoms might be prescribed IV antibiotics if also they are if the infection is deemed resistant to just the PO antibiotics. Moving on to viral infections, herpes simplex or HSV type 1 is usually found on the face, typically known as cold sores. Type 2 is typically considered your genital herpes, found on the genitalia. Severity of the herpes really depends on your age and immunocompromised status, and secondary infections can occur. And reactivation of the virus is often triggered by stressors such as sunburn, trauma, fever, menstrual cycle, fatigue. So after you first get infected with herpes simplex, the virus remains dormant in your nerves, and then those stressors causes the reactivation. And the virus travels down those sensory nerves to your skin. It can be droplet or contact spread. Outbreaks usually last about 3 to 10 days. You're contagious for the first 3 to 5 days. What does it look like? As you can see in this picture here, they're grouped vesicles with the reddened base that can become pustules that can weep and crust over. They can itch, they can sting, they might be painful. So because it's caused by the herpes simplex virus, we treat it with antivirals such as acyclovir, valacyclovir, and famiciclovir. Herpes zoster, otherwise known as shingles, is another type of viral infection. It is caused by a reactivation of the dormant varicella zoster virus in those that have previously had the chickenpox. So if we suspect shingles, we really need to be asking these patients if they've had the chickenpox in the past. The lesions are found mostly on the anterior posterior trunk, following what we call dermatomes, dermatomal distribution, following a pathway of a spinal or cranial nerve, because that's how the virus travels and lives along your nerves. You're most contagious when the blisters are filled with fluid. So you need to be on airborne and contact precautions until the lesions are dry and crusted. Usually if we get a patient in the hospital setting, we might utilize infection control nurse to really make sure that we are doing the proper precautions. She'll be able to look at the lesions, and she'll also maybe look at whether it crosses the midline of your spine or trunk to determine the proper precautions. And their lesions are typically very painful, and even after the lesions do go away, patients might experience post-herpetic neuralgia, and they may be very, very painful. We do treat it with antivirals like acyclovir and valacyclovir, and those are most effective as they are started as soon as the symptoms start, and they reduce viral shed, decrease symptoms, and decrease severity and duration of the illness. And some important points for patient education teaching for herpes prevention: communication with your partners, talking with physician or counselors, and educating yourself, maybe joining a support group. And with the herpes simplex virus, especially avoiding intercourse if either partner has an outbreak of herpes. And for the shingles virus, you can prevent it by getting the shingles vaccine and also getting the chickenpox vaccine, so you don't get chickenpox in the first place. That doesn't turn into shingles eventually. Avoiding those stressors is also key. And moving on to fungal infection, your tinea infections. These are called dermatophyte infections. And then these fungal infections, that tinea is followed by where exactly it's located. So tinea pedis is your feet or athlete's foot. Tinea manus appears on your hand. Tinea cruris is on your groin, or otherwise known as jock itch. Tinea corporis is all over your body, typically known as ringworm. Capitis, scalp. Barbae is beard. Depending on the species of the dermatophytes, they can live mainly in the soil, on animals, and on humans. And superficial infections can start only when the infecting organism comes into contact with impaired skin and a susceptible host. They're spread by direct contact with the infected humans or animals. And they're characterized by annular patches with elevated borders, scaling, central clearing, so you'll see a little bit of a clear middle with a almost reddened ring on the borders. And it can be very, very itchy. So you can get over-the-counter treatment, antifungal lotion or cream like your Lortermin and Lamisil, but you might need other forms of antifungals, whether it's shampoos, PO, things like diflucan or fluconazole. That you might get as a prescription if the tinea infection is severe and doesn't respond to the over-the-counter antifungals. And even after successful treatment, you can still see the lesions for several weeks or months, and the infection can return in certain types of weather in the summer when it's hot and humid. So how do we prevent these fungal tinea infections? So we need to make sure you practice good hygiene. So making sure that we do things like avoiding walking barefoot in bathrooms, locker rooms, gyms, public areas. Making sure that we take care of our fingernails and toenails. We make sure our feet are nice, clean, and dry, discarding old shoes, boots, slippers, sneakers, don't sharing footwear, things like that would be good education points. Another common fungal infection is your candidiasis, also known commonly as your yeast infection. They love to grow in a warm, moist environment. Risk factors include immunosuppression, long-term antibiotic therapy. Yeast infections can be considered superinfections when you're on antibiotics for a long time, destroying the good, healthy bacteria, so you're more prone to these yeast infections, secondary infections. Diabetics certainly have increased risk for infection, and obese patients that have excess skin and body fat where they love to live. They are mostly reddened areas. They're moist. They might be itchy. They might be burning. Thrush is particularly in your mouth or oral lesions that look creamy and white, and your mucous membranes might be inflamed. How do we treat these yeast infections? So depending on where it is, we can use PO for the mouth and airway, like nystatin, PO clotrimazole, fluconazole, and also in your esophagus. On your skin, you can use topical nystatin or miconazole that we typically see, and also vaginal candidiasis, you can use clotrimazole, miconazole as well. Key teaching points for prevention of these yeast infections: keeping our skin nice and clean and dry. We might use drying powders, making sure that they're exposed to air before we put on clothing, and making sure they're nice and dry. So we really only want to use antibiotics when necessary, because these fungal infections are fairly common after antibiotic use with the secondary infection. And they are present under excess skin folds, like abdominal folds, underneath the breast. So it might help if you try to lose weight. And also controlling your blood sugar for diabetics will also help decrease chance of infection. A parent's worst nightmare might be that they get a note sent home from their child's school saying there was an outbreak of lice. We all know and have heard horror stories of lice infestations. They are a type of parasite. Pediculosis capitis is your head lice. Pediculosis corporis is on your body, and pediculosis pubis is pubic lice. cause intense itching. And you might physically see the nits at the hair shaft base, wherever you have hair. This is typically seen more in patients with poor hygiene or in communal settings, maybe showing signs of self-care deficits. Not to, put out a stereotype, but we do want to be aware of that for these patients. And they can be contracted from bed linens or during sexual intercourse, so contact isolation, because it can be spread through close contact and sharing personal belongings. And how you get rid of them is using special shampoo. You want to rinse and dry the hair, apply the medicine to the hair and scalp, wait about 10 minutes, rinse it off, check for the lice and nits again about 8 to 12 hours, just to make sure you get rid of all of those nits. And using a fine tooth comb to try to take the eggs out if you do visually see them. And prophylactically, other household members may also receive the permethrin treatment. We do want to wash our clothes in hot water and make sure they're dried at high heat. Also cleaning things like combs and hairbrushes also in hot soapy water. We also want to make sure that anything that can't be washed, we seal it in plastic bags for about 2 weeks until the nits die off. And we can also vacuum as well. And the over-the-counter medications that are available are based on pyrethrin that is extracted from chrysanthemum that is known to be toxic to lice. Scabies is another parasitic infection that's caused by the Sarcoptes scabiei mites. So they burrow under the skin and actually leave track marks. So you'll see these pictures, you'll see kind of horizontal white skin ridges caused by the burrowing of mite into the outer skin layers. Especially at night, it can cause severe itching. And the hypersensitivity reactions to the mite results in that erythemas, papules, pustules, crusted lesions, especially on the elbows, maybe on the chest, lower abdomen, buttocks, thighs, and the axillary folds. So we really want to inspect the skin, maybe also between the fingers, on the palms, and on the wrists. We can use permethrin, lindane, urax, ivermectin as an option. And again, like lice, the healthcare provider will usually recommend treatment for all household members in close contacts. Because of the itching, we can recommend cool, wet washcloths for pain relief, calamine, and antihistamine for itching. Moving on to dermatitis, which is contact dermatitis, a type of inflammatory condition. It's also known as allergic dermatitis. It is a result of a delayed hypersensitivity reaction to a direct contact with a specific irritant or allergen. Several hours or day may pass between the contact with the allergen and the reaction. It can be microorganisms, chemicals like cosmetics, hair products, plants, think poison ivy, poison oak. Some people might also develop a reaction to metals like nickel. You can develop contact dermatitis to things like latex. So we really want to look at where you see the reaction or the rash. So it can be a clue to what the antigen might be. Maybe your hands were exposed to a chemical, or you noticed that you developed a rash on your wrist after you wore a bracelet or something like that. They can be localized eczematous eruption with erythema, edema, pruritus, vesicles. So because it's caused by a specific irritant, what do? We remove the irritant after we identify it. Because it causes inflammation, we might give steroids and antihistamines for itching and inflammation as well. and comfort measures, maybe cool, moist compresses and lukewarm baths. So in contrast, atopic dermatitis is a chronic condition. We don't know exactly what might cause it. Food allergies can make atopic dermatitis worse. Children that have atopic dermatitis might have food allergies to milk products, nuts, and shellfish. It's a chronic condition made worse by dry or irritated skin, food allergies, chemicals, or stress. So it's an underlying chronic condition that can be exacerbated by certain triggers. You see erythema, scaling, thickening of the skin, and because you might have a lot of itching, you might open up your skin, and that can lead to infection. It's most common in children, areas that have cold weather or polluted areas, and you often see a family link with atopic dermatitis as well. So we want to avoid those irritants that might cause it, and use moisturizers, control inflammation and itching. And if that does develop into infection, we want to treat the infection as well. So basically the difference between contact and atopic dermatitis is contact. Think, going back, hypersensitivity reaction to a certain irritant, versus atopic dermatitis, a chronic condition that people might have a genetic link that can be made worse with food allergies, stress, or chemicals, but it's not considered an allergic reaction. Okay, psoriasis. You see these thick red patches covered with scaly, silvery scales on usually the scalp, elbows, trunk, knees, and limbs. Borders are sharply defined. It is an autoimmune disorder. You have exacerbations and remission. It results from the overstimulation of the immune system, the Langerhans cells in the skin that activates T lymphocytes. These cells then target the keratinocytes, causing increased cell division. So you have the overstimulation of the Langerhans cells that really cause increased cell division and plaque formation on your skin. So you have red patches with silver scales. You might be exacerbated by infection, hormonal changes, stress, certain drugs, obesity. It actually can improve with sunlight exposure, interestingly. So we want to tell these patients that it's an autoimmune disorder, so you're not contagious. You can't spread it to any of your close contacts. And some patients with psoriasis might develop debilitating psoriatic arthritis. And this arthritis may lead to severe joint changes similar to those seen in rheumatoid arthritis. So we do know that this psoriasis is an autoimmune systemic disorder as well. So just briefly on the treatments, we can use corticosteroids, vitamin D and vitamin A derivatives for the anti-inflammatory effects and to decrease that cell division of your cells on your skin. We can use tar preparations also to decrease that cell division and to decrease inflammation. We can use UV light, otherwise known as PUVA therapy. The patient actually ingests Sorlin, which is a photosensitizing agent, before the treatment. It usually takes about 16 to 19 treatments to put the psoriasis into remission that can last about 8 months. And the therapy sessions are limited to 2 to 3 times a week, not usually given on consecutive days. And it can cause darkening of the patient's skin, which is a normal side effect of that PUVA therapy. Because the Sorlin is a photosensitizer, patients must wear dark glasses during the treatment and for the rest of the day. And for severe psoriasis, we can use systemic therapy, maybe even your biologic response modifiers or your immunosuppressants. And skin cancer is actually the most prevalent type of cancer. Sunburns can cause skin cell damage that can lead to skin cancer, and there's no way to reverse the effects of the UV from the sun. Dark skin people have more protection than fair-skinned individuals due to the higher amount of pigment in the skin or melanin, but they still can develop skin cancer. Major cause, again, overexposure to sunlight, that UV light. Risk factors, if you have light skin because you don't have those melanocytes, older age, maybe with repeated sun exposure, depending on your occupation or lifestyle, you might be in the sun a lot, and also genetics. There is a genetic mutation linked with specifically melanoma. There's different types: basal cell, squamous cell. The squamous cell is the most commonly seen on head and neck. Basal cell is the most common form of skin cancer. Malignant melanoma is highly metastatic, so early diagnosis and treatment are key. And Kaposi sarcoma is specifically associated with immunosuppressive states, specifically in your HIV and AIDS patients. So we need to biopsy any suspicious lesions to determine if they're malignant or not. Want to teach patients the ABCDE rule for early skin cancer detection. A is for asymmetry. So if you draw a line down the middle of the lesion, the left and right don't look similar. B, border irregularity. If you have irregular borders to the lesion. Color variation, if you have a mix of colors, maybe some parts are darker than others. If the diameter or size is over 6 millimeters. And E is for evolution, if there's been any change in size, shape, color, if it's become a little bit elevated, or if there's new symptoms. Again, going over the A, B, C, D, E. So the left side is what benign lesion might look like versus the right side, which is malignant. So the top picture, the malignant column, the right side looks a little bit different from the left. You have irregular borders for B. You have a mix of colors for C. You have the greater than 6 millimeter diameter, and if there's been any changes. And nursing implications, just as a brief overview, for any type of skin infection, you want to assess for risk factors, maybe look at some of their social situation, hygiene practices, what their symptoms are, where the lesions are, what it looks like, if they've been in recent contact with anyone with those skin disorders, what their stressors are, if they've been vaccinated, especially against chickenpox. So we also want to emphasize skincare with proper cleansing, and implement proper transmission-based precautions, contact, airborne, whatever you have it. Want to make sure they understand drug therapy, whether it's bacterial, viral, parasitic. Want to prioritize that patient and family education is key to prevent the infection from spreading to other body areas or to other people. Want to control their pain, implement comfort measures. For inflammatory skin conditions, again, assessment is important. We need to identify the cause. For instance, the contact dermatitis, what is causing that hypersensitive reaction? Comfort measures for inflammation, and we want to teach the patient about the disease process, what the treatments are, and provide emotional support for psoriasis, especially because it can change, have an impact on their body image. And some points on skin cancer prevention and education. To avoid sun exposure between 11 and 3 when the sun's rays are the strongest, using sunscreens, wearing hats, opaque clothing, basically covering up your body when you're out in the sun, keeping a body map. Secondary prevention or early detection is critical to survival, especially with melanoma. So we want to teach everyone to be aware of their skin markings, keeping a total body spot and lesion map to provide a baseline about suspicious new lesions and help identify changes in existing lesions. And once a map is made, they should inspect their body monthly for new lesions and changes by performing a thorough skin self-examination or SSE. You might take pictures of their skin on a regular basis, And we want to make sure to tell patients to evaluate all skin lesions using the ABCDE guide for melanoma and consult her physician to examine any lesion having unusual features. And they should be monitored yearly when things like moles are present. They should be monitored yearly by a dermatologist or other healthcare providers. So that is your skin disorders in a nutshell. Again, you have your handouts, you have discussion board, and certainly let me know if you have any questions.